Just one quick announcement after this. After this session breaks, we would encourage you to join us for our networking lunch from 11:45 to 1 p.m. And you just want to go out those doors on the left and make a left, and we'll make sure to guide you down there. It's a little bit of a turny thing, but we'll have plenty of students to help you. We hope you take that time to meet participants and colleagues and really enjoy the lunch. And with that, I'll open it up to Cliff to start the panel. Thank you.
Great, Caden. Thank you very much. I am not as smart or as good looking or as insightful as Kavita Patel, but I will do my best to sit in for her. And I'll have to apologize when I see her because there's nobody like Kavita. Welcome to our session 2 on incorporating clinical nuance into Medicare Advantage plans. And you know, when Medicare Advantage was written into the Medicare Modernization Act of 2003, you can be pretty sure that it didn't have the phrase clinical nuance. So this is a little bit more than a decade since then, and just the fact that nothing like that at all appeared in the language, and now we're seriously considering it, is at least some indicator of progress. Today, I think we have to keep in mind that when Medicare fee-for-service was set up, all beneficiaries, and still to this day in fee-for-service, are subject to the same cost-sharing structure for clinician visits, for diagnostic tests, for prescription drugs, regardless of their clinical value. Now, private plans are participating in Medicare Advantage. They have some leeway for innovation. For example, in network formation, in certain provider-directed interventions like quality-based bonus potentials, certain forms of utilization management. So, although Medicare Advantage can establish differential cost sharing based on service categories, based on facility setting, still CMS does not permit differential cost sharing based on the provider group chosen by the enrollee, or allow tailoring of the benefits to specific groups of patients. So some leeway, yes, but not the kind of thing that looks at all like VBID. Now, CMS and certainly CMMI in particular, the Center for Medicare and Medicaid Innovation, are starting to look at VBID as a promising strategy in this field. And so today what we're going to do is examine how clinical nuance, and by that we mean anything from heterogeneity of treatment effects, patient preferences, differences in individuals' capacity for health gain for any given intervention, how clinical nuance can become integrated into this very important leg of Medicare. Also, I really hope that our speakers will help me kind of dive into an important current development coming out of CMMI that could have a lot to do with accelerating VBID in Medicare Advantage and Medicare Advantage prescription drug plans. We'll kind of leave that a little bit to the end, but there's something going on like this week, and November 3rd is a key date for that could accelerate some of this positioning here. Well, we're going to have 3 distinguished speakers here today, and from your left to your right, start out with Randy Krakauer. Now, I know everybody's got the bios and stuff, but just to kind of remind you who these folks are without reading the whole thing, Randy is VP and National Medical Director of Medical Strategy at a little insurance concern called Aetna. You might have heard of it. Among many other things, Randy is responsible for medical management planning and implementation nationally for Aetna's Medicare members, including program development and administration. So this is what he is about. You'll next hear from Mark Hamelberg, who's next to your right. He's the Senior Vice President of Federal Programs at America's Health Insurance Plans, AHIP. He's got more than a couple decades worth of experience in the private sector and public sector. He was a senior official at CMS and spent some time, did his time, I should say, at the Department of Treasury. It seems like Treasury keeps kind of coming up here. I guess that happens when you're spending as much money as we spend every year in the Medicare program. Our third speaker, and to my immediate right, is Joe Baker. Joe's the president of the Medicare Rights Center. And I must admit that I didn't know about that until I saw that you're in the program, Joe, and looked it up. And we need our Medicare rights exercise, certainly. Among other things, he's a member of the IOM's Board of Healthcare Services, but he serves on the Center for Medicare and Medicaid Services advisory panel on outreach and education. And clearly, when you get to these issues about VBID, as we heard in the earlier panel, consumer understanding, comprehension, and implementation is key here, and that's part of his job. So Let's start with Randy Krakauer. Randy's probably going to give us a look at the broader payer perspectives on VBID and some payer issues in Medicare and Medicare Advantage. Randy, you are up, sir.
Very much, and I'd like to thank Mark, the VBID Center, and all of you for the opportunity to speak to you today. Medicare medical management presents us with the potential to impact both quality and cost in ways that can't be done in regular fee-for-service Medicare. Classic utilization management can extract unnecessary costs from the system, and there is potential for facilitating medical services that are necessary and appropriate in the most efficient setting and means. One aspect of utilization management that has reduced costs are co-payments and deductibles for medical services and drugs. Utilization management also provides us limited opportunity to improve clinical results. In Medicare, the real opportunity is presented by populations with risk factors, chronic illness, and advanced illness. As one progresses to another, we're presented with opportunities to impact the cost of the illness and the life. Hypertension to ischemic heart disease to heart failure, metabolic syndrome to diabetes to renal failure, osteoporosis to hip fracture. The list of conditions with prevalence in Medicare is considerable, and indeed, over 70% of cost is generated by a population with more than 4 chronic comorbid conditions, many of them inadequately managed. 2/3 of a Medicare population has hypertension, many inadequately controlled, who will develop preventable strokes and heart attacks. We seek to identify risk factors and conditions and alter their course with the tools we have as physicians, health plans, and others. Medicare members' health and costs can be impacted favorably by successfully addressing risk factors and care completion in chronic illness. Health plans with Medicare Advantage need to provide for such impact to improve quality measures, such as STARS measures, and to reduce cost in order to in fact even be viable. The impact needs to be real, measurable, and to increase over time as the bar is continuously raised. No such imperative exists in traditional fee-for-service Medicare. To accomplish this, we provide a variety of care management and member educational services, which vary by plan. The goal is, through education, outreach, adherence programs, and other means, to improve health and reduce cost. We provide case management, disease management, home transitional care visits. We send reminders for flu shots and occasionally offer incentives. We work with physicians and other providers with ACO-like arrangements and offer incentives for physicians for better quality and cost outcomes for their patients. Indeed, we do in fact get impact. If we didn't get impact, we wouldn't be here at all. But we probably leave more behind us than we carry with us. As diabetes type 2, for example, progresses from metabolic syndrome to diabetes to nephritis, neuropathy, peripheral vascular disease, etc., the cost also increases from 1.36 times mean to twice mean to 7 or 8 times mean. So prevention or substantial delay of progression can improve health and also save cost. Having said this, the job is not easy. First of all, with the exception of heart failure, most conditions such as diabetes can progress over years. And if there is a potential to reduce costs through preventing cardiovascular sequelae, it's likewise to be achieved over years rather than in a single year, which is the way one might affect premium. In addition, the type of impact that would be necessary to substantially delay progression of diabetes would require multiple interventions rather than a single intervention. So it's going to require a combination of everything we have available in the most aggressive possible manner to achieve it. So one, we need a means to accomplish this, and two, having accomplished it, we need a means to capture the value of having done it, neither of which are easy. Such progression in diabetes can be inhibited by lifestyle changes, diet, exercises, adherence to medication, and other means. While we expend considerable effort to accomplish this, we also throw up barriers with deductibles and co-payments for medication necessary to control blood pressure and blood sugar, for retinal and foot exams, and other services that should be encouraged. These are the same co-payments and deductibles that are designed to reduce cost and in fact do reduce cost. The effectiveness of these barriers, of course, vary from individual to individual, but it should be clear that in some cases they're counterproductive in terms of our efforts to provide favorable impact at the intersection of quality and cost, at least in cases in which the drug or service needs to be encouraged. So doing this is not going, and identifying these opportunities and doing them will not be easy. And capturing this value in terms of premium is also not going to be easy, as it could require years. Were we to calculate the value of adherence in such situations, we find it varies with the condition, the intervention, whether it's primary or secondary, and comorbidities, for example. Ideally, for example, we might want to calculate the value of a beta blocker in a particular member with heart failure at a particular time. We might be able to approximate this, at least on a population basis, and we should have sufficient data now to find some good opportunities. Heart failure, for example, provides us an example with a short-term impact potential, but most chronic illnesses, most of our best opportunities are in fact multi-year, whereas most of our contracts are single-year. Excuse me. I can't speak for all health plans or Medicare Advantage plans because they're all different, but they all have a common need and responsibility to improve both quality and cost, and a limited number of tools available for this purpose. The ability to match a cost of a drug or service to its clinical and economic value is something that's not been available to us in Medicare in the past. As we mentioned here, it appears we might be able to take advantage of this potential soon, and we and others are going to be responding to this RFI with some very interesting and concrete proposals. And this experience in the area with our commercially insured population is that enhanced prescription coverage enhanced prescription coverage, improved medication adherence rates after myocardial infarction, reduce patient costs without increasing overall health costs. This should be a very valuable and effective tool in Medicare, where such opportunities abound. With the opportunity apparently becoming available, we can develop plans to improve the health of our members and medical costs by combining value-based insurance design with our other tools, including education, case management, provider collaboration, member incentives, and other tools to create impact greater than the sum of the potential for each individual effort by designing these tools in a particular condition to work in synergy. We might seek to enhance coverage for prescriptions and other services deemed to be of clinical value commensurate with such value as part of an effort to delay or effectively prevent, for example, the progression of diabetes type 2, ischemic heart disease, or multiple comorbid conditions and risk factors. This will require a careful study of each clinical opportunity, both as an independent variable and in combination with some other impact tools. Once opportunities are identified and a comprehensive program created, it will be necessary to study the impact immediately and over time. A data-rich environment is clearly necessary, which is most often the case in Medicare Advantage. Value capture is another matter that needs to be studied. Capturing value for something that will occur over years requires either a multi-year contract, which is something that's very difficult to achieve, or a very careful observation of disenrollment rates and decedent rates, which over 5 years, even when they're low, can amount to something that is considerable from an actuarial perspective. A considerable amount of work has been done in value-based insurance design. The availability of Medicare Advantage populations with the preponderance of target-rich populations will accelerate the work in this area and will create a milieu in which this is more effective. We'll plan to create a comprehensive program to improve health outcomes of many of our members while simultaneously reducing cost, and we expect these savings to increase over time for each of our targeted members. This will be of benefit to our members, Aetna, our participating providers, and health policy. We look forward to some very hard and rewarding work beginning with the response to this RFI. Different health plans will do this differently, and from varied experience, we will learn in increments how best to do this. We now have the potential to work our magic on a population rich with risk factors, chronic illness, and most important, with potential. Thank you.
Thank you. Before we move on to Mark, you seem pretty excited about VBID. Is that right?
I would say that I am. I think it gives us a tool that we never had before. I'm excited to use it and I don't want to get into an argument of what constitutes prevention, but I am interested in using it in ways to prevent the progression of chronic disease. and I'm looking to use it in synergy with other things that are already that we're already using to make what we're currently doing more effective. This is not going to be easy, but it's something that is very important and I think very worthwhile.
Speaking of the progression of disease, can you go back to about page 2 of your presentation? You gave some progression ratios. You flew through those. Could you restate those, please?
Ratios?
Yeah. As we move through our diseases and get older.
Hypertension to ischemic heart disease to heart failure.
And you had a number there.
Actually, I do have some numbers.
No, you quoted a few numbers there, some ratios. 1 point. Yeah. Yeah, from the mean, ratios off the mean.
Oh, okay. Metabolic syndrome costs 1.36 times mean.
Yeah.
Diabetes without defined cardiovascular sequelae about twice mean. And diabetes with nephritis, neuropathy, significant cardiovascular sequelae can be as much as 7 or 8 times mean.
7 or 8. That's what I thought I heard. So there's a heck of an opportunity for VBID to make a difference.
There is a heck of an opportunity. And it is our responsibility to find out a way to realize it. And that is going to require significant impact on the behavior of members. And I think it's not going to be easy, but I think we need to employ every tool we have and employ them in synergy. And I think this is giving us a potential, incremental, valuable tool that we never had before.
Excellent. Points very well taken. Thanks for going back there. Mark Halberg, you are very well positioned at AHIP to kind of comment on the future of it. Go ahead.
Sure, thank you, and thanks for inviting me to be here. I want to build a little bit on what Randy was talking about, maybe look at the industry a little bit more broadly and focus also a little bit more specifically on some of the obstacles that are out there. But before I start, and maybe as an obstacle for this discussion, by raise of hands, if you feel like you really understand what the MA program is, could you raise your hand?
I have to raise my hand.
Okay. So I'd say, please. So I'd say it's maybe 50-50. So for those that already know it very well, if I could beg an apology for a minute or so, just to level set for the others so they can maybe benefit from the discussion as much. So, and there's a lot of misconceptions, and as somebody who's had to walk his mom through all of these issues, I'm more versed in this perhaps than I would even like to be. So, a couple of key points about the Medicare Advantage program. It is a voluntary program. It is available to individuals who are eligible for Medicare, aged and disabled primarily. It is run primarily by insurers, like Aetna, there are other companies, large, small, typically provided as either an HMO or a PPO. So in the form, most of them are in the form of the types of plans that are available in the commercial market. And by law, they are required to at least offer all medically necessary Part A, which is inpatient coverage mostly, and Part B, physician outpatient services, drugs, and other associated services. So the plans must offer those as part of the benefit. They can, to some degree, they can vary cost sharing from what fee-for-service has, including, as an example, where in fee-for-service Medicare, original Medicare, there's 20% cost sharing for a physician visit. In Medicare Advantage, they can have set copays, and they can have different copays for, they can develop networks, so they can have different copays for in-network and out-of-network. MA plans also must have maximum out-of-pocket, sort of a catastrophic limit. And the way that they are compensated for this is that they are paid a capitated payment by the government. The plans will bid on the cost for providing those services and any additional supplemental benefits that they wish to provide. The premium that a beneficiary may be charged is a function of how that bid compares to CMS-established benchmarks that are also sort of created by statute. And for some plans, beneficiaries will pay their regular, what is it, about $100 now, Part B premium, and they won't have to pay any additional amount for the MA coverage, and in some cases they will have to pay an additional premium, again, depending upon the bid and the level of coverage. And the other thing to know is that an MA plan can also include in its package of benefits Part D, which is the outpatient drugs, also added by the 2003 law. So it's essentially an alternative way for Medicare beneficiaries to receive their Medicare-covered benefits, and to do so with designs that differ in some ways from the fee-for-service benefit. The overall scope is at least as generous, and in many cases more generous than the fee-for-service benefit, and it includes, as I said, some lower cost sharing, oftentimes an integrated Part D benefit, and various other services that I'll mention briefly in a second. So that's what Medicare Advantage is. And it's also important in having this discussion, I think, to understand the scope of Medicare Advantage as we sit here today. Now, when I was in the government, I was there from 2004 to early 2009. And just to pick a random number because it works nicely, in 2007, there were about 8 million beneficiaries enrolled in MA. There are now just under 16 million. So the program has doubled in that period of time. There are about 99% for 2015, I think it is 99% of beneficiaries have access to an MA plan in 2015. That's actually down a tick from prior years, and we can talk about why. But still, on average, beneficiaries across the country have a robust set of options that they can choose from in MA, and it is, by all accounts, and roughly 30% of the Medicare population is enrolled in MA, and that's been growing over time. So it is an incredibly impactful program that affects that and enrolls many millions of Medicare beneficiaries, many of them very vulnerable, a very vulnerable population. Okay, so why the growth of MA? Again, I think to put it in the context of VBID, it's really to understand what are plans doing. Again, this builds a little bit on what Randy was talking about. I think what the MA plans have been able to do, despite some of the obstacles that we'll talk about, and that Randy sort of alluded to also, that MA plans by and large have found ways to offer high quality, and for many people, higher quality option for accessing health care than they would in the Medicare fee-for-service program. And they've been able to encourage, both through their arrangements with doctors and in education and other ways with beneficiaries, a more efficient use of health care. Higher quality, more efficient use of health care. I think that's what the MA program has been striving to do and has, in my opinion, done, which is why it's grown the way it has grown. Just a few data points to support that. For 2015, roughly 60% of beneficiaries who are enrolled in plans for 2014 will have their plans be at least 4 stars or higher. CMS has a star rating program, and that star rating program will adjust payments to MA plans if they achieve a certain rating. And as I said, roughly 60% of beneficiaries enrolled in plans that will have that at least a 4-star rating or above. It's on a 5-star scale, starting in 2015. And again, those numbers have been going up every year that the star rating program has been in effect. So beneficiaries are choosing quality, and plans are offering higher quality based on the various metrics that CMS has developed. Surveys show that 90% of beneficiaries are satisfied with their plans. 94% satisfied with the quality of care that they're getting in MA plans. I think those are incredibly important numbers from a health policy perspective, and also just sort of understanding the potential for VBID. And also, MA plans outperform the sort of unmanaged care that beneficiaries get in the fee-for-service program on a whole range of quality metrics, whether it's breast cancer screening, diabetes care, cholesterol testing, readmission rates, and other quality metrics. While there clearly are things that can be done better, and I think that's really where the VBID opportunities are there. Given the restrictions that the plans have been operating under, I think we really can say that they really have done a great job, frankly, of focusing on those types of quality metrics. In fact, plans are required by CMS to have quality improvement programs and chronic care improvement programs. And they use the sorts of tools that Randy was referencing: care coordination, disease management, for those that offer Part D benefits, medication therapy management. So many plans, particularly those that are special needs plans or SNPs, but also I think many MA plans also have a concerted focus on disparities in care, and whether it's based on income, whether it's in certain minority communities, language barriers, really focusing on vulnerable populations and finding ways to help those beneficiaries access care that they're otherwise having trouble accessing is a really, sometimes an untold story of the MA program, and I think it's an incredible focus of many MA plans. Well, how do they do this? Just to sum up, I think that their ability to contract with providers gives them the opportunity, whether it's through education, whether it's through contracting that requires, whether it's credentialing providers to be in their network, and then contracting with those providers and including in their contracts financial incentives, reporting, and quality standards to ensure that they're using evidence-based protocols for delivering care. That's all a major part of it. And then the ability to, through higher cost sharing for out-of-network benefits, it can incentivize beneficiaries to use the providers in the plan's network. Now, there are limits. They have been up until now, and I'll touch on some very welcome news that CMS has come out with very recently on this. But up until now, there have been limitations on the ability within a plan's network to further drive beneficiaries towards the most high-quality care. And part of that is for beneficiary protection reasons. CMS requires that plans have an adequate network of providers, particularly in some geographies that can make it hard to draw distinctions for the most high-quality providers. But as I said, CMS, and I keep teasing this, but CMS has made some changes recently that will, I think, be very valuable. I'll get to that in a couple of moments. I also mentioned earlier that CMS does allow some cost-sharing distinctions with some limits, some cost-sharing distinctions. So within the actuarial value of the benefit that an MA plan can offer, it doesn't have to offer the same design as fee-for-service. So there are ways that plans through that design can try to highlight and create incentives for using particular types of care. And plans are measured. They measure their quality internally, and you've got HEDIS measures and other quality measures, the star ratings programs. And I've heard many people say over the years that you can't have improvement if you don't measure what you're trying to improve. So I think MA plans really, whether it's through HEDIS and other measures, are highly, these sorts of measures are really both from a reputational aspect and just for helping the plans identify areas to change resources, or really helping plans try to find ways to get the highest value care. So what are the limits that we've seen? Well, from a VBID perspective, the primary limit has been CMS's interpretation of the law that says that, as by and large, plans must offer uniform benefits to people enrolled in plans. And what that means in practice is that plans cannot, for example, have different cost sharing that rewards or incentivizes beneficiaries that have a particular need to use the highest value care. Basically, cost sharing established has to apply to everybody in the plan in pretty much the same way. So and it also applies to premiums, applies to deductibles. There's all the sort of cost sharing around that. And that is a significant limitation. And I understand, and having been at CMS, I have a real appreciation for the concerns that CMS has had over the years. And I think some of these we even mentioned on the earlier panel. Concerns about discrimination against individual beneficiaries. Concerns about improperly limiting access to care by beneficiaries. Concerns about limiting choice. And as the program has evolved, I think CMS has consistently had those sorts of concerns. And frankly, I think it's appropriate for the agency that is regulating these plans to have those concerns. But I think also with the evidence built up over the quality and the fact that actuaries at CMS are predicting that some of the really historically low per member spending in Medicare is coming to an end, is going to start shifting, that making sure that we have high value, efficient use of health care is more important than ever. And of course, with the baby boomers and the cohort that are entering the Medicare program, it's just that much more important than ever that policymakers figure out ways to use the tools that they would have at their disposal to try to get at the highest use and most efficient use of health care. And that's where VBID comes into play. So a couple of points on that. Number one, and sort of maybe building to some of the most important issues. CMS in a regulation that they put out in May indicated that they would be changing rules that would allow MA plans to provide rewards and incentives to encourage participation in certain wellness types of activities that focus on preventing that focus on promoting improved health, on using healthcare resources effectively. These sorts of rewards, they can't be cash rewards, so they're going to be limited in value. We're still waiting for more guidance from CMS, but directionally, the idea of encouraging incentives for these types of wellness activities within MA is a good development. The next thing, which I teased a few times, is that in the call letter that CMS puts out the final comes out every April, they indicated that they would be clarifying a rule, which frankly was a change in my opinion, but they've clarified their rules so that plans will now be able to offer within the plan tiered cost sharing, so differential cost sharing within providers within the network as a way to incentivize individuals to use higher value providers. So that is a really good and important development. And then lastly, we've got VBID and the Innovation Center RFI. So just a couple of words on that, and I'm sure in the discussion we'll go into that in a lot more detail. Sure. Well, maybe I'll just I'll hold off as a teaser so that nobody will leave before we get there.
No, because we do want to focus on that in just a minute.
Yep.
Thanks very much, Mark, and thanks for the enlightenment for the first few minutes. I think that brought us all to the second. It is very helpful. So given that VBID, as it approaches the Medicare program is starting to think about VBID, it still is important for Medicare beneficiaries to have, retain, and know their rights, as it were. And so from the Medicare Rights Center, we give you Joe Baker.
Thank you.
Joe.
Thank you. Just a little level setting for the Medicare Rights Center, because we're a little less known than AHIP and Aetna. So we're a not-for-profit organization in New York and Washington, and just to give you an example of the way we approach this, and I used to work for the state of New York and ran Health and Human Services out of the governor's office there, so have my feet in both places many times. And my goal in leaving government was really to organize consumers around these issues and make our voice more effectively heard. And for example, on the board of the Medicare Rights Center is someone like Bruce Vladeck. John Blum just joined our board, and Simon Stevens, who used to be at United Healthcare and is now running the NHS in Great Britain, was on our board. So we have, I think, a very eclectic approach here, and one that is trying to kind of really find a navigable path for consumers through a lot of these things. Two initiatives that we're engaged in right now. One is we just, with a group of consumer organizations, won the contract from New York State to be the Ombuds program for our fully integrated Duals Advantage program. So, a lot of people say, oh, consumers are against, managed care for duals. No, we're not. We want the right managed care for duals. And certainly there's no one better than me and many of the clients that we work with that knows how fragmented and bad the fee-for-service, pure and simple program can be for duals and for everyone else. That said, a lot of managed care organizations use fee-for-service for their providers in various instances. So fee-for-service has a role. We're also got the contract with a partner in Iowa to be the national backup technical assistance resource center for the SHIP program, which is the 50-state program that helps people with Medicare figure out what to do and what options to take. So your mother can call us as well as calling you. So just to give you an idea of where we're coming from, I think where we are at in VBID, and we're very much engaged with Mark and had invited Mark to speak to a group of consumer advocates in Washington, because guess what? You got some work to do with consumer advocates on VBID and with consumers generally, as we've been discussing. But we really believe that it's a discussion that should have and a movement that should move forward. Certainly with Medicare, we're interested in the demos. We want them to move forward. We really want them to start with carrots, not sticks. And I think that's what we're talking about here in a great degree. Let me give you a couple issues, and we can tease these out or not. But so preventive care in Medicare. Wow, ACA, fabulous. Everybody loves it. Good. And it is. But most of the calls that we get about preventive care, or I went to the doctor and they actually removed a polyp and the whole thing I had to pay for. What's up with that? This is like a bait and switch. These providers are crooks. The whole thing is a sham, right? Now, I would say, well, wait a second. That was the whole point, to find that polyp. That's not the way they see it. So they're scared to go in for preventive care because provider always finds something and then it changes the code, and they end up paying for something when they thought it was free, okay? So that's number one. Wellness visit. Oh, I thought it was a physical. Oh, it is a physical. I've got to talk to my doctor, and then he does something, and all of a sudden I got to pay for that too, right? And this is both in the fee-for-service program and in Medicare Advantage. So, watch what you wish for, watch what you design, and I hate to say it because there's a lot of providers in the room, but there's a lot of wily providers out there, right? So if you don't have them on board, you don't have consumers on board, because that's who they listen to. They're not listening to Aetna. They're listening to their doctor, who's supposedly an Aetna system and the Aetna doctor, but is he or she really? So something to think about. The other thing we need to think about, and the reason I say carrots and sticks in the Medicare program, just have to say it, 50% of seniors, these are Kaiser numbers, have incomes under $23,500 a year. They got a lot less money to play with. They're already spending 15% out of pocket for medical costs when under 65s are paying about 5%, right? So you put more sticks in there, they ain't going to darken your door. They're just not going to come. And we see it in the donut hole. Rand study from, 1902 or whenever it was done, on and on and on. So, they're pretty rational. If it costs more, they're just not going to go, or they're going to find another way to do it, or, steal Aunt Sadie's pills, So I think that's an important thing as we move forward. So I think we should move forward, but the design of it, the education, and I'll get to that in a second, are going to be critical. So monitoring of this kind of plan design, and we talked a little bit, mentioned about discriminatory plan design. And, flexibility is, I think, important and needed. One of the things that ACA did was there was a lot of flexibility in what plans were doing with regard to cancer care and skilled nursing facility co-payments. And that was taken away by the ACA because we saw a lot of plans increasing co-payments in those areas, really as a way of cherry picking, we think. And so, we go back to, and I'm being a little provocative here, but and certainly when Medicare Plus Choice, I was around then, you had Betty White on a bicycle eating an apple saying, hey, join Medicare Plus Choice. You did not have the woman on a walker saying they give great vascular care for diabetics at U.S. Healthcare. Join up U.S. Healthcare if you need, to prevent or get vascular surgery or prevent vascular surgery. So, that's, part of this kind of risk selection, and gaming. Many of the plans aren't doing that. Certainly, that's not what's happening, but it does occur still. And that's why we need the monitoring, and that's why we need the right design, and we need the right oversight. And I think we have been getting that. And I think groups like AHIP and others are bringing plans together for best practices, and I think that's the plan. The program is a lot different than it was in 1998, and that's a good thing, and we still have work to do, and I think we're all committed to doing it. Value, I hate to say it, I think we might have to find another word, because if you look at stuff that Consumer Reports does on healthcare and that we also have done, consumers hear value and their little antennae go up and they're like, wait, isn't there a thing in the supermarket called the aisle of value, and isn't that where all the cheap stuff is? And so they are a little skeptical. I think it's odd that, and I'm speaking now about consumer advocates as opposed to consumers, I really had a job to do in New York to say, no, we should get behind this duals program, even though it's managed care. And they were like, well, why? We have PACE, and PACE is great. And I said, well, if you like PACE, that's the most limited network in the world, and everybody loves PACE. So let's just try to make this PACE without walls, let's if we can get there, can we, so now's our opportunity to make that happen. So I think if we can, talk to consumers in the same way, I think this stuff has to be very transparent, has to be very provider-driven. And even when it's provider-driven, my best example, choosing wisely. We all love choosing wisely. It's, Consumer Reports is behind it. Everybody, it's specialists. They say you don't need a chest x-ray before general surgery. New York Times front page article, example, no chest x-ray before general surgery. You've got the Heritage Foundation spokesperson and some doc that say, well, some people might need it. And, and then somebody said, my cousin got a chest x-ray before general surgery and they found a tumor. And it's like, okay, so that everybody over 50 should get a chest x-ray, every year just to make sure they don't have a tumor. So you've got this battle of providers. And, same with mammography, as we well know. You start putting a value-based design in there. We're only going to pay for mammography. You can pay for your own mammography every year, but we're only going to pay for it every other year. And then you've got some provider in the program that says, I think it should be every year or every 6 months. So it's really, once again, if you don't have providers with the program, they're the ones talking to consumers. It doesn't matter what the plan says. That's a bad plan if they don't pay for mammograms every year, even though it says they should. And I mean, honestly, what we really do need to be talking about is maybe it shouldn't be covered at all. Maybe PSA tests and prostate care shouldn't be covered for any men over age 80 or 85. And that's because it's just as bad, or it's just as useless. I shouldn't say bad because I might need cosmetic surgery, but it's just as useless as cosmetic surgery for vis-a-vis your health, right? I'm not talking about psychological health. So that dissonance amongst providers and doctors is a gigantic piece, and consumers feel whipsawed by that dissonance and plan design. And so I think that's an important thing to keep.
The distance between what and what?
Well, the kind of that distrust, or that space between provider X and provider Y, and then plan X, plan Y, and then plan and doctor. All of that dissonance of disagreement between those, or potential disagreement, is a place where consumers throw up their hands and end up saying, okay, I'm going to listen to my doctor. That's the person, or the nurse, or the nurse that whispers to me in the hall. Well, this is a way to get around that. And so that is, I think, something that we need to deal with, because we hear about it all the time. And so education, ongoing education, because we're never done being educated about anything in this life. We need to think through, who is it? Is it plans? I don't think so. I mean, they're a part of it, but I don't think they're the major educators. Is it government? Part of it, but not the primary source. I think it's really provider and consumer groups. I mean, we have created in New York this consortium of provider and consumers with the plans in the background, and engage with us on how to educate providers about FIDA. The duals program in Massachusetts has incredible opt-out rates. We want to avoid opt-out. In California, they have great big opt-out rates. We really think the fully integrated Duals Advantage program in New York can really work. If it's designed right, we think it's designed right. We're going to have to change it. Medicaid managed care, when it came to New York, everybody fought it tooth and nail. It has changed the landscape of New York in a very good way in the Medicaid program. So, big believer that it can work, but it needs to be tightly monitored, tightly regulated, we believe. That doesn't mean it needs to be always tightly standardized. I think some of that helps. And I'll just close with one thing, and that is that the other thing that we have to think about as we think about flexibility, which I do, once again, advisedly so say I'm supportive of, is the biggest problem that we have is choice. And that is two things. One is most people in the Medicare program think of choice as choice of providers, and they want as many, that big a choice as possible. They're willing to give up some of that, as Marge's research shows, and for other things, right? But so put that aside. But to choose amongst 30 health plans, your mother, yourself, your sister, whoever, if you've helped them, to choose amongst 30 health plans is just well nigh impossible. And, Kaiser and others have done great study about people that just lock in. Like, I've always been with United. I've always been with Aetna, and I've always been with AARP, whatever it is, even though it's not the best deal for them. They have no real support to make a decision. They throw up their hands. It reminds me of when I went shopping for cabinet pulls for my kitchen, and I went to the cabinet pull store. Have you ever been to a hardware store that has like 70,000 cabinet pulls, And I thought to myself, boy, in the Soviet Union, they had silver, gold, and wood, and they were out of the silver and gold. You just took the wood, You painted it, and they worked, So, we always have to balance that, I think, choice, which I do believe in, and options and flexibility and people wanting to design things for themselves, to are we overburdening consumers and overwhelming them so that they just make no choice whatsoever? And is that the same at age 65 as age 85? And so I think, with that, I'll leave you.
Great points, Joe. You really highlight the need to deal with this, with the different constituencies out there, consumers, and particularly this consumer dissonance thing going on. It's consumer dissonance and the observation of different expectations, requirements among their docs and providers. That dissonance is upsetting. You just outlined this you call it the biggest problem is choice. So consumers are basically flummoxed by having to make decisions across 30 different health plans. You're not done with the consumers, because then you got to move on to the providers. You got think tanks, political pressure groups, and others. So
I don't care about them.
Oh, just you wait. All these groups have something to say there about this. So even if sort of analytically and econometrically we can come up with VBID as a good solution here, there are many other sort of battles to be fought here. I have a question, just going back to Randy and Mark for a second. Both of you talked about kind of Medicare Advantage, how it's designed, how it's working, the star ratings and so forth. So Medicare Advantage was not designed to anticipate VBID sometime later. But it sounds, Randy, from some stuff you said and a few things that Mark said, that there's some aspects of Medicare Advantage that might be decent receptor sites for VBID. But how close is Medicare Advantage to being, if you will, retrofittable to VBID? It wasn't designed with that in mind, but there's some elements in it that might kind of enable VBID. I don't know if you thought about that before, but Randy, what do you think?
Yeah, well, first of all, there is simply the preponderance of a target-rich environment that we're dealing with. Secondly is the fact that we already have an infrastructure in most MA plans for care management, not just utilization management. We have, in various forms, we have case management, we have accountable care-like arrangements with multiple different provider groups everywhere. We have provider contracts. So we have the milieu that's already in place to facilitate this, and also to synergize with this. That is, VBID alone. I mean, if you have heart failure and I just suddenly say beta blockers there'll be no co-payments on beta blockers right now. In order, first of all, even I need to tell you about it for it to have any effect at all, really. But what you really need to do is do that in the context of a program which will identify this population and work with them and manage them and help them to realize the potential of VBID. We have that infrastructure already in place in, I'd say, probably most Medicare Advantage plans right now, because I think in this year of 2014, I'm not sure there are too many Medicare Advantage plans that don't do any of that anymore.
Right. So there is kind of fertile ground there, perhaps, for VBID, eh?
We already have the clinical and the care management milieu to enable this to be done and done better than in either a fee-for-service environment or a commercially insured environment.
Got it. Mark?
Right, and in addition to the structural opportunity, legally, my view is there's nothing from a statutory perspective that would inhibit it.
There's nothing there legally?
No. Well, it's a set of regulatory rules that I believe CMS could change. So we were talking in the earlier panel about, whether there might be some legislative hurdles for the use of VBID and HSAs, and whether there may be regulatory strategies. Here, in my view, this is to facilitate VBID. This is entirely within control of the agency, CMS.
So nobody's got to pass yet another law,
No.
you're saying? But
No.
they can tweak the regs to make it work.
They can tweak the regs, they can modify the regs, or actually a lot of this is in sub-regulatory guidance, to be honest.
Even
It's not
sub-regulatory
It's not even
guidance.
in regulations, it's in the manual, it's in call letters, it's in HPMS notices, there's a whole industry of guidance on a sub-regulatory basis that CMS provides to the plan. So a lot of this can be addressed in that way, and as we, again, have alluded a couple of times, there's the Innovation Center, which has the ability legally to allow for variation in design, even if there were a statutory hurdle. So the legal mechanisms are in place, and as Randy was saying, I think the structural mechanisms are in place.
And are the reward mechanisms in place? Does the star rating system kind of help or hinder in this case? Randy?
Well, I mean, it helps in the sense that it ties your financial success to quality metrics. Now, you can argue with whether or not the star measures are the best possible measures, and there's always an opportunity to improve them. But the fact that quality performance is being tied to financial performance does create the already extant opportunity to make this worthwhile. But also, the star measures themselves are not necessarily permanent. And once you can show that this approach is successful and worthwhile, there's an opportunity to modify star measures to make this more effective.
So they could be modified in a way to sort of better align with VBID if that's the direction they want to go.
Yes.
Aha. So Joe,
Yes.
alignment, is it retrofittable for VBID? Medicare?
Oh, I think it is. I think
Yeah.
what's interesting is that we're, I guess, in the camp of let 1,000 flowers bloom. So you mentioned ACOs, and there are other, payment mechanism and delivery system reforms that are being piloted right now that do bring providers and plans, and either formally or kind of back office, the plans are doing everything, and the providers are out front. Together, because I think no one has the information technology resources that many of the plans do, many of the PBMs do, to bring to bear to help providers. So I think in the ACO context, whether it's in the ACO context or in the MA context, I think that there is a tremendous opportunity right now, given big data, given IT, to kind of really move the ball forward. I start with the carrots because I'm not as sanguine about the law in the sense that you may very well be right, but I think if we started with a lot of sticks, I think we'd get a lot of pushback from consumer organizations, trial attorneys, et cetera, saying, "Oh, well, wait a second, the law is there, and Social Security, gets sued, and or HHS." So I think, definitely we're at an opportunity that needs to be taken, and that some of these constructs that have been built and are being built, like ACOs, are there. I think the other great promise, going back to my provider plan problem, is providers and plans are getting together in much more cohesive ways and sharing risk. And while that can be a scary thing for some consumers, I think that can also be an opportunity, once again, if there's proper oversight and monitoring and it's based upon real metrics and data, to have that better coordination and better practice, both on the plan side and on the provider side, because I think both have something to learn from one another. So I think that overall is a good thing. As a consumer advocate, what it means to me is, you don't have, and I'm using this in a very gross way, but in the bad old days, it was black hat insurance company and white hat doctor, right? The hats are kind of graying now because they're getting together. I think once again that's a good thing for clinical and other reasons. I think for consumers it starts to be like, okay, who do I go to really get the skinny on this? And I think consumer organizations will need to step up in a way that maybe we haven't, and maybe we haven't been resourced to be able to do.
Exactly. So we're going to do two things. We're going to open it back up to the audience. Number one, we're going to go back to the main barriers to making this work, and Joe did a great job of setting this up with regard to consumers and providers, in particular, kind of the barriers that might be there. Talk a little bit about that. Then I'm going to ask Mark to introduce the RFI, just to give us some particulars on that, and then we'll have a great basis upon which to have a broader participation here. So, like I said, Joe talked a lot about the consumers and providers insofar as kind of the barriers and obstacles. Mark, what else do you see? What is the single most kind of important thing in the way of a successful application of VBID for Medicare Advantage? What's getting in the way? You said that there wasn't a legal barrier.
Right. Well, I think there's no statutory barrier. There is a legal barrier, which is the CMS uniform benefit concept.
There you go.
Approach.
Right.
That is the single biggest barrier to MA.
And is it anything we can overcome? Do we have to do kind of an end run around through CMMI and some other provisions? Or
Well, effectively, that's what's happening, I think, is that CMMI is essentially saying, and this is not from any inside information, just my interpretation of it, is that they understand with all of the work that's going on in the commercial space and just sort of looking over the horizon with, as I said earlier, with the baby boomers, just the numbers of people being covered by MA projected over the coming decade, and increasing cost curve going back up, that there has to be a better way. And that the concerns that they have, and I acknowledge, I think those concerns are appropriate concerns for a regulator to have, but you still need to be able to, with the health policy issues that are at stake, find ways to allow plans to develop approaches that might lead to more effective care. And I think also part of what's, again, my own personal view, is part of what's driving this is things like the Dartmouth studies and other studies that show that higher utilization of care doesn't mean better care, doesn't mean better outcomes. And I think the agency, whether it's through the star ratings and through a whole range of other places, that for so many years we've been focused on procedural issues and this idea that more is always better. And I think the data, the analysis, and just the sophistication of people on these issues has evolved to the point where we understand that it's the outcomes that matter. And I think the agency, through a series of steps that really started in the mid-2000s, but it's continued and expanded, is that the agency is singularly now focused on ways to try to get better outcomes. And I think VBID is a way that's very consistent with that mindset.
it is, but we're still, there's a statutory barrier, right?
A regulatory barrier.
We're dealing with something that was written, actually drafted, more than a half century ago. That's where the statutory basis of this thing arises, right? And we're still having to deal with that. And all the things that you mentioned, Mark, have changed not only during the course of the 50 years, but especially in the last 3 to 5 years. A lot of change there. So that's still in front of us. Randy, what about it? What's in the way here?
Well, yeah, I mean, as we indicated, some of a good deal of the regulations that have been written have precluded any effective use in Medicare Advantage of value-based in design, and that's the reason we've done it on the commercially insured population instead, because that's where we had that opportunity. And I think again, I'm just going to interpret what we're seeing coming out of CMS with this RFI. They've taken a series of opportunities that have been suggested to them, and they have asked for input as to what can be done to make this better. And as you point out, a lot of this are regulations and statutes left over from long ago. So, and this particular RFI is not just VBID is prominent in this RFI, but there are other things there too. I mean, the hospice benefit, for example, was written decades ago, and you have to abjure curative therapy to be eligible for Medicare hospice, which we and others have clearly shown that this is an unnecessary barrier at this time and probably should be eliminated. Well, that's also in the RFI, as are several other things. So I think CMMI is doing exactly what they are, what the statute gave them the opportunity to do, and that is seeking input for changes that can be made without essentially without change in statute, which they already have the authority to do, and. VBID figures prominently. There are several questions in this RFI specifically related to VBID, and I think we will be given, my personal opinion on the subject, having talked to some of them, is we will in fact be given the opportunity to implement some of this.
There you go. So, Mark, give us the executive summary, synopsized version of this RFI, and I'll just toss out to everybody, the date's November 3rd, so far as responding. So, like, this is happening like now. Mark, give us the kernel of it.
Right. So the RFI is focused on MA and MAPD plans, and the specific questions that they are asking has to do with cost-sharing incentives, whether through co-pays, deductibles, the out-of-pocket cost, and reduced premiums, so the whole gambit of potential cost-sharing provisions, whether incentives could be modified to encourage beneficiaries with specific chronic conditions to seek high-value care. That's really the nub of what the RFI is doing. CMS also asks a whole series of questions trying to get people's ideas about, is it a good idea or not a good idea? So that, basic yes, no, and why or why not. But what they're also asking through their questions, you can see how they're trying to figure out what conditions would it be appropriate to target? How do we track quality measures? What sort of beneficiary protections would be appropriate to include in these sorts of arrangements? What types and levels of cost-sharing changes would be appropriate? Will this save money to CMS, and how do we think that would happen? So from a health policy perspective, these are, I think, the appropriate questions to be asking. And the RFI is trying to solicit information from all stakeholders on these various issues. And it seems to me that folks associated with the center, that it would be incredibly important for as many people as possible to weigh in on this.
Yep. Hey, Joe, you going to weigh in on it?
I think so.
I bet he will. So let's open it up. The first I see a hand in the far corner. Name and affiliation.
Uh-oh.
No, Mark Fendrick. I don't know who I am, but I'm feeling like I'm in Star Trek, like Dr. John said earlier. So this is a spectacular panel. I think one of the nice things in tying it to the last one is this idea that prevention does not always equal value. And Joe, you articulate that as a non-clinician, the fact that you may get a free normal colonoscopy and someone with a family history that requires a colonoscopy every year has to pay full price or whatever that is, just suggests we need to really work hard on these semantics, whether it be commercial plans or public plans, and I think that's very key. In Medicare, we spend 98% of the dollars on chronic diseases. So, and Mike Chernew reminds me all the time is that before you start talking about the merits of VBID, remind people about the status quo.
Right.
Cost-related non-adherence in Medicare Traditional and Medicare Advantage. John Ayadian wrote one of the first papers. Will Schrank has written, who's in the audience, several other papers. The evidence is overwhelming that even in Part D, which was passed to improve access to high and low value pharmaceuticals in Medicare beneficiaries, those benefits are eroding in the status quo, which is why we feel that some type of strategy to reduce cost-related non-adherence is essential. While some might love to have cost sharing reduced on everything, which is not tenable, I think the only way out of that then is nuanced cost sharing. So this is why, like MA is voluntary, the VBID demos we're talking about in MA are also completely voluntary, and if you build them and they don't come, Aetna wouldn't build them anymore. So I think that this opportunity to move it forward. So, Joe, my question ultimately is for you, and one point that wasn't raised, that in addition to the administration and CMMI and CMS looking for more information on VBID, There is a bipartisan, bicameral bill in the U.S. Congress. So I can repeat that again: bipartisan and bicameral. Understanding for those of you who don't spend time in Washington, like the folks, CMMI is not a very popular aspect of one of the political parties. In fact, they, I believe, have not said anything positive about anything that CMMI has done outside of value-based insurance design. Just to note to the audience that just this really kind of unusual situation of the strange bedfellows moving on.
And back to your question.
My question is, we, like you, will respond to the RFI saying in Medicare, the demos have to be carrots. And in the legislation, it is explicit about being carrots.
Right.
I wanted to talk a little bit about the politics of the fact that some people in Washington just don't like MA. They just don't like HSA, high deductible health plans. And how do we kind of break through the fact around the partisanship of the politics, even though we have this incredibly broad coalition saying this is probably a good idea to move forward in this carrot-only fashion?
How about it, Joe? That's your
Well,
job, man.
yeah. Well, if I had that key, I wouldn't have any problems whatsoever. I think a couple things. I think one is, the work that you've done on the Hill, Mark, and that the organization has done, it needs to continue. But you've made considerable and I think consistent progress. I think secondly, there's always going to be, the hardliners on either end that, okay, just don't even visit them anymore, But I think there is a growing place in the middle. And I think, particularly around bills like the bipartisan bicameral bill, and I think consumer groups might have been in a place, over to the left, try to ignore them and try to strong arm them. But I think they're coming into it, given some of what we've heard today, given some of what you're saying. So they need to bring along some of these legislators that have a knee-jerk reaction. And we get calls all the time. What do you think about this? So, for example, some of the folks on the Democratic side in the House are not very friendly to VBID or some of these, or the duals program that CMMI is putting forward. And by the way, the duals program isn't just managed care. Connecticut is doing a managed fee-for-service. There are lots of flowers blooming, as I said. So I think what we need to do is build this coalition of plans, of consumer groups, of academics and think tanks. And where we do agree, because there are a lot of places I think we agree, there's a core that we agree on, that we are vocal about that and say, so we're saying to, the sponsors of this bill and others, yeah, we're worried about the slippery slope, but hey, the whole world's on a slippery slope and everything. But this bill right now works, and somebody say, oh, well, what if the secretary is a different person than the secretary is now? Well, we already have a different secretary. We'll be there. We'll burn tires in the street if we have to, but you can't, you can't stop the change momentum is building. And right now, this is good, and we're supportive of this. We're not just kind of like let it wash over us. We're supportive of this. And by the way, here's a Christmas ball that we want on it. Or here's something else that you can do to make this, more palatable or more attractive to consumers, or might not be related, but helps us out in selling it to our constituency.
Great. I have this mental image, Joe, of you with a headband and a cut-off T-shirt burning a tire on Pennsylvania Avenue.
I wouldn't do it because it's bad for the environment.
It's not pretty. So I saw two hands. Yes, the gentleman on the aisle. Name and affiliation?
Gil Oman, University of Michigan.
Thank you, Gil.
Hi. So a couple of you mentioned data and multi-year data for patients, but I don't think anybody mentioned the electronic health record. In other circles, this is a flaming subject. Tens of billions of dollars have been force-fed into the system without incentives or requirements for interoperability or user matched to workflow for nurses and doctors. It is a red-hot issue for doctors, nurses, institutions, both for effectiveness and for costs. I'm wondering from where you sit and on this topic, if you see positive opportunities from the electronic medical record and ways some networks are using this information, I think, quite effectively.
Yep.
And if you see problems, Joe, with the complaints from patients, that the doctor is more interested in the screen than in me, and for reasons that irritate the doctors and nurses who have to enter all this information and bring forth out-of-date information by cut and paste and many, many other serious problems.
Thanks, Gil. You know, short-term, long-term problems. Short-term, a heck of a lot of complaints. Long-term, it may be the right way to go, especially if some of our older clinicians decide to retire and go do other things. But ultimately, do the EHRs, electronic health records or EMRs, electronic medical records, are they going to be something that will kind of help accelerate adoption of VBID or get in the way? What do you think, Randy?
Well, I think in the long run, ultimately, they will be helpful, particularly if if the physician working with the case sees all the options in front of him on the screen, which he won't right now.
Right.
And if we implement a program within the next year or two, that won't be the case. But I think ultimately it will be helpful. I think it's right now. We are in fact struggling with access to electronic health records by case managers with communicate. Well, we have another with the ability to communicate through these records. So I would separate out short term from long term.
Yep. Anything else on that, Mark? EMRs, EHRs?
Well, just to say that I think these are important issues, and where they play out, not being a clinician, but what I've seen is oftentimes in transition of care settings where good medical record information could be most important. That's sometimes where it's often most problematic.
Yeah.
Getting, it's sort of a timing issue and a sufficiency issue, and needing it at the time when it could be most useful.
Yeah.
And
Right.
That's what we have to work on. It's the ability to share information, which is not necessarily present in the systems that have been implemented
Yes.
today.
Yeah, Dr. Ullman, just to add to that, I don't see how VBID works if you can't take the big data and marry it with the EMR data so that you can help make these considerations with the patient in real time to advise them and so forth. It can't work without those. Point very well taken. Name and affiliation.
Kathleen Nolan, National Association of Medicaid Directors, and I wanted to, I'm struggling, we've been talking a lot about how to get people into these programs, but not so much what happens when they are in them and how do we make sure that they're effective. And if we're going to be looking at this in 10 years and finding out whether it worked, last panel Paul said that it took him 5 read-throughs to figure out what was free in his plan.
Right.
Just 5.
So yeah, just 5, and he's the lawyer probably, so I don't know what it is. So I'm struggling with, let's create enthusiasm, let's structure these well, let's get them there, but how do we make sure that once consumers are enrolled, they actually know how to effectively use these programs, use the value-based, or are we just counting on them being so finely tuned that if you're enrolled in the right VBID plan, we don't have to worry about you anymore? Is that really where we are?
Joe, does it drive itself or what?
It doesn't drive itself. I think 2 things. One is that you either have to have providers driving it, because they're saying you need this because it's free, and I'm going to provide it for free, and that's where the problem of this, the colonoscopies that we've talked about is it comes into phrase. So you either need to have providers driving it, or because the plans can drive it, but these are the problems, right, with the documents, and so they could do better in that regard. So I think you either have to have providers driving it, or you have to set up a whole infrastructure that we don't have. So, for example, when you have a claim for your homeowners or for your car insurance, let's use homeowners, you really rely on the broker to help you structure your claim. We used to do that with medical insurance too, right? And some employers still do it that way. The average consumer doesn't have that and doesn't read their policy. And when they do read their policy, they have a problem and they're panicked and they call us. And we're not adequately resourced, nor state insurance departments or other state-based organizations to do it. So I think it's a new infrastructure. Maybe it's the exchange, and the navigators and the consumer assistance programs, which are not refunded to do this work. So I think that's something we need to think through.
Thanks, Joe. Randy, on that point.
Thank you. Yeah, no, as I indicated, we would not think that this would work extremely well as just an isolated standalone. Like I indicated, suddenly there's no co-payments for beta blockers if you have heart failure. There has to be a support infrastructure present around it. So we would implement it in as I indicated, in concert with with case management. We would do it within accountable care-like organizations where hopefully we have the support infrastructure necessary. So when the intervention is done, the physician is familiar with it. The case manager is involved and knows about it, and there is an interaction with the patient so that the rest of the support structures are present in concert, and this will act in synergy so that the impact that you get will be greater than the sum of all the pieces, one of the key pieces being VBID.
Excellent. Thank you. Row 2, row 6, wall back. That's the order. All right, thank you. Try to remember it. Yes, sir.
Wow.
Row 2, sir.
Roy Ramthod with West Health. Just wondering if the concept of special needs plans within Medicaid, Medicare Advantage offers a platform to maybe get around some of these uniform benefit issues as the potential barrier that's out there now. I mean, maybe we're focusing on the wrong special needs, but if you turned it on its head to say maybe the special needs are people with chronic conditions or something like that, would be the platform for designing something that would appeal to those right beneficiaries and maybe not bring with it the uniform benefit baggage that you've identified.
Mark,
I can start. There are a couple of issues to think about. It's an interesting question. I think, obviously SNPs are not available everywhere and they're limited in scope. They do have a far more extensive, whether it's models of care and individual care plans. They're very person-centric, which is what I think a lot of this really comes down to, in my opinion. But I think there are still, even within that structure, there are still limits on the ability to use VBID that changes in the rules can facilitate. But I think it's an interesting way that maybe within, who knows, the data will be what the data will be, but perhaps VBID within a SNP will see different outcomes than VBID within the broader range of MA plans. Just, I don't know if this is helpful for anybody else, but it's been helpful for me. I was on a panel some time ago and had people talking about the difficulties of dealing with particularly vulnerable populations. And they said that a lot of the incentives in the health system push towards a low-touch approach, but the real success at a person level is with a high-touch approach. Mm. And to me, the way VBID can work is by allowing plans to effectively focus on people who would most benefit from the high-touch approach. They can use the resources in an effective way. If you treat everybody as a priority, then nobody's a priority. And that, to me, is how VBID sort of, so I think of high-touch, low-touch. To me, that's my shorthand of saying, yeah, VBID could be a way to allow the high touch that all of the people on the ground would say is the only way to really move the needle for a lot of people, particularly vulnerable populations, but really for almost anybody.
Great, thank you very much, Mark. Woman in row 6, please. And just, we want to use our time efficiently, so concise questions and concise answers. Yes, please.
Lee Rucker, Enhanced Value Policy Consultancy, previously for many years, AARP Public Policy Institute. I want to come back to something that Dr. Krakauer mentioned in your opening remarks, in that for dealing with chronic care patients, really a multi-year perspective is beneficial, yet your contracts are single year. And so I'd be interested in hearing additional thoughts on that. This came up recently, earlier this month. Dr. Fendrick and I were both on a specialty pharmaceuticals panel, and concerns with the huge upfront costs for patients going on Sovaldi when those patients may not be in that particular plan in future years. My experience focusing in Part D, and particularly medication therapy management, which is also addressed in this very instructive RFI, looking at how to make MTM more robust. When benefits may accrue or may not kick in until towards the end of the plan year, but then you definitely want to enhance the medication management in following years as well. So anything you can add more on that. Thank you for raising that.
Randy.
Yeah, well, we've discussed this many times in the last few years in many different forums. It is a significant problem, and particularly so in Medicare, where we have the greatest burden of chronic illness. With the exception of heart failure, the chronic illnesses in general evolve and impact over multiple years, and in most cases, the impact in 1 year is not going to be terribly great. So essentially, we're being incentivized to do nothing about chronic illness. Now, that's not in fact what most MA plans are doing. They're in fact doing something about it, but the key is not just doing it, but the ability to capture the value of having done it, which is really hard. Well, in individual Medicare, you can't write multi-year contracts. In group Medicare, you at least have the potential for multi-year contracts, but it ain't easy to get them to convince a client that there's value in doing it. You can look at disenrollment rates, and in fact, disenrollment rates in Medicare Advantage in general are relatively low. So you can say, our disenrollment rate is, our decedent rate is 4.6%. Our disenrollment rate is only 4 or 5%. It's not that great. Maybe we can value it based on that. But then if you carry that out for 4 or 5 years, even a small number like 8 or 9 or 10% times 3, 4, or 5 years gets very significant, and then the actuaries start having fits. That you can't looking at the value going that far. So what I'm going to say is it is in fact something we need to do, something we are addressing, something that is quite a challenge, but something we're. But what I could tell you we have looked at, we've looked at risk factors in chronic illness and the multi-year opportunity. Some of them are just too far in the future to capture. So, for example, if you look at hip fractures, you can do fall prevention. That captures the value in 1 year. But if you do that alone, they're frail old ladies. They're getting older. They're getting frailer. You might have just delayed the fracture. You might not have really prevented it. You can look at the bone mineral density, and you can look to build up the bone mineral density to the point where you're above the quote fracture threshold. That's about a 3 or 4 year effort. You have to find a way to value that and capture the value. Right. But what was the approximate cost of it? 25 or 30 years ago, she had a premenopausal hysterectomy and wasn't put on hormones. No way you're going to go back 25 or 30 years and capture value. We feel that you can capture, in 3 or 4 or 5 years, you can capture 55 to 65 to maybe 70% of the value if we can find a way to do it.
Okay, thanks for picking up on the point that he made earlier. It's exactly value capture over time and how the premiums are reflected. I want to get these last 2 questions in, so concise questions and answers. 1, 2. Yes.
Yeah, this will be short because that was kind of my question. My name is Paul Hughes, Cromwick, Altarum Institute Center for Sustainable Health Spending. So let me just add a follow-up. You're saying that you're doing that, Dr. Krakauer, you're doing that virtually. You're not doing that contractually. Is that correct?
We do have some group Medicare contracts like that. So we're seeking to do it contractually, but it's a very hard sell for group Medicare, a multi-year contract.
Okay, good, thank you.
I'd love a multi-year contract for my small group plan that was inflation protected. But the free market in the United States means that I bought Aetna last year because it was 10% less than the Oxford renewal, and this year it looks like Oxford's undercutting Aetna. So tell me what to do. With regard to Medicare, it's a social insurance program that's nationwide. I guess big data needs to find a way we do risk adjustment across these pools. Maybe there's some big, gigantic value adjustment we can do so that it's a Sovaldi patient who gets it in the Aetna MA plan but dies healthy in the Cigna MA plan. Cigna kicks back to Aetna. That's somebody else's job.
Or away from the Sovaldi, there are also ways, maybe even through the risk adjustment model, to incentivize earlier identification of diseases. And,
sure.
I mean, CMS has really been moving in the other direction on risk adjustment. So,
yeah.
just a commercial for that.
By the way, just to keep it up to date, Sovaldi's already behind the curve. It's now Harvoni.
Harvoni.
And it's not $1,000 per pill, it's $11.25. I bet Krakauer knows about that.
Depends how sick you are. It's a real value if the Hep C is not quite as advanced.
Yes, yes. Speaking of what? Value-based insurance design,
that's
right? Give it to people. Okay, last question from the floor, name and affiliation.
Hi, I'm Will Schrank from CVS Health. This is for the whole panel. It's my impression that CMMI has been rather non-prescriptive in its payment models. They largely contract with providers and give them an incentive to do better and to reduce total cost of care. And they haven't been prescriptive about how providers do that. And what's exciting about this new RFI is that now MA and MAPD and standalone PDs are in the mix. They have not to date been part of the mix. But what do you all think about sort of CMS being prescriptive about testing VBID in particular versus offering some sort of a non-prescriptive shared savings or broader payment model that gives the plans the opportunity to implement VBID, but gives them a great deal of flexibility in terms of what it is and ultimately that they implement?
That is a great question, Will. Mark, take a flyer at that. Basically, do you call it VBID or do you call it something broader that might enable or allow VBID?
Well, it wouldn't shock you to know that I would be supportive of flexibility, but I think the reality is, and just my guess, and you certainly know this, Will, just sort of the way the agency is structured, my guess is that there's a hesitation. You've got the Center for Medicare, which is responsible for administering and enforcing the MA rules, and you've got the Innovation Center that's offering their approach. My guess is, just pure guess, that whatever the Innovation Center does, it's going to be mindful of the significant structure that's already been in place for other MA plans, and they're probably going to want to make sure that there's at least some limitations in place so that it has at least some connection to the existing program. Just a guess. I would be very supportive of allowing a significant amount of flexibility for the plans and for members to be able to find the most effective way to use high-quality care. But my guess, again, I don't want to sound pessimistic, but my guess is that CMS will get pressures from a lot of different places and will probably come out with maybe not going as far as we might like them to go, but it's still a pretty far way. And I think directionally, it's exactly the direction to go. I hope that makes some sense.
Good deal, and good. Thanks for the question, Will. All right, closing question. We're going to start with Krakauer, move to Baker. Answer this in one sentence, please. Not a paragraph, not a thesis. Or doctoral.
I can't do that.
Yeah, I know you can do it. I know. Okay, so Randy, and it's tough for you because you don't have much time to plan for this, Baker. You can't repeat anything else anybody else said.
Okay.
No dittos here. So,
favorite.
Randy, it's October 22nd, 2020. We're here, this room, you're on the stage. And I'm going to ask you at that time, hey, VBID worked. By 2020, it was not only put into some kind of provision, legal, statutory, whatever it is, not only did it kind of get the legal to push off, it worked and it's been implemented and it's cranking along just fine. Randy, what happened right? What's the single most important thing that enabled this thing to be cranking on all cylinders in the year 2020? One thing, Randy.
We found a way to implement it that was effective, and we found a way to capture the value of having done it.
Capturing the value of having done it. Thank you. Mark, what's the one thing that made it go?
The outcomes. Ultimately, the data shows better health, better outcomes.
So there is the reward and the risk. Thank you. Joe, what made it go?
I think we started with the demonstration projects, with the carrots, with the input of all stakeholders from the RFI, and CMI very deliberately rolled this forward. and then scaled it up appropriately given that experience.
Excellent. Please join me in thanking Joe Baker, Mark Hammelberg, and Randy Clark. A great session. Thank you so much. Thank you.
Thank you.